I'll do a quick introduction. Annie is a trustee of our charity, and we're absolutely delighted she's a trustee of our charity. You're also a trustee of Pernicious Anemia Society, I think,
Yes.
and is really exceptional person. You can see the Queen thought so too. She has an MBE, works all over the world, but actually Annie can explain about herself better than I can. So I will hand you over. Thank you very much.
Thanks, Hugo. Yes, well, I don't know if you want to know all about me. You can go on the website, anniebarr.com, if you want to read lots. But basically, my background is in nursing. I was a strategist for the Department of Health for many years in chronic disease management and long-term conditions and cancer care. And have always been interested in B12 deficiency for many years. Maybe in the late 70s, early 80s, when I started nursing, I saw a lot of people in psychiatry. I did psychiatry at first, and I saw a lot of people with what was diagnosed as pernicious anemia who had also had dementia, and it got me sort of thinking about there may be a connection, and so that was kind of where it started, which was, as I say, late 70s, early 80s. And then I never really thought much more about it over the years. And then it would be about 2008 or 2009 when I came across Dr. Chandy, and I was looking for some good literature and information and stories, patient stories, and I was writing a B12 course because I had by that time started a company, a professional development company, so training and professional development, and my very first course was B12 deficiency and pernicious anemia, and it was the very first course that I ever wrote. And I thoroughly enjoyed it, and I got lots of information from this charity, and really began to sort of explore lots of things, and I quickly realised that it wasn't a popular subject out in sort of NHS land, and so it was quite difficult to kind of get people to understand it. So anyway, I wrote the course and got it accredited through the RCGP. I sat on the board of the RCGP for quite a few years in the Northeast. I just resigned about 5 or 6 years ago to give somebody else a chance. And because I just got too busy. And then I've done a lot of work in places like China. I could write 2 or 3 volumes on China alone, but I won't. And then got involved in really doing I had lots of people who wanted to come and see me for B12 injections, and so I started my own clinic, and I really do that just to get it out in the open, but also for people to be able to self-inject. So that's what I do it for. So I do have people who come and see me on a regular basis for B12, but not that many compared to the hundreds that I see and then teach the nearest and dearest, or a spouse or relative or the person themselves to self-inject. So that's what I do. And then, so today I really wanted to, you guys are all, far more expert, I assume, than B12 than I am, because I do have B12 deficiency, so I will declare that. But I don't have it anywhere near the way that, you guys have had it. I think probably, maybe I got it early enough, I don't know, but my mum died in 2018, and it was after that, really, that I started to look at the family history and saw there was a direct correlation between symptoms that she had, and then I looked at the family, and I just thought everybody had it. Two grandmothers had B12 deficiency, pernicious anemia, and then all the family, the female, particularly the female line of the family, have B12 deficiency and pernicious anemia. So my levels were quite well, they were 230 in 2016, and I've got the energy. I run around the country and the world, so I don't lack in energy. But anyway, I lacked in other things, which was sometimes focus, and I did get excessively tired when I sat down, when I actually allowed myself to sit. So, but I really don't have any of the symptoms, lots of the symptoms that you guys have had, and, had the difficulty getting the B12 or the diagnosis or anything. I didn't experience that at all. But I do deal with people all the time who have that issue. And one of my I'm passionate about B12 deficiency, because I don't think people know enough about it in general. You guys know, but Joe Blogs out there really doesn't know, and certainly the medical profession, a lot of them don't know. So I think it's I feel like really privileged to be able to help to educate people about it. And on Thursday, I had a captive audience of about 400 at the College of Naturopathic Medicine in London, and educated all of those people about B12 deficiency. So it was a very interesting day. Okay, so just to say, we're also a training college, so we do Scottish vocational qualifications and apprenticeships and other courses as well, just day courses or 2-day courses. We have offices in Fitzroy Square in London. I have office in Jedburgh, which is where I am now, and then Metropolitan House in Gateshead, and that's some of the team in London. So enough about that. I'll move forwards. So really the aim today was to talk about the basics around the cofactors. This is not going to be like an in-depth, scientific analysis of everything. It's just going to be a fairly basic, and how important it is to get the basics right. Sometimes we don't get the basics right, and it's really important to understand why they're so important, and how things work together, and how things are, it's much better to to have certain levels higher when you're on B12, with folate and ferritin, than maybe the reference range would say. So I'm not saying go out with the reference range, I'm saying be the top end of it. And so I just wanted to talk a little bit about that and my experience with people who haven't responded as well as I thought to therapy, B12 injections, and did so after introducing cofactors. So types of supplements you can get in the UK are hydroxycobalamin, which of course is what probably most of you are taking or get from your GP. Cyanocobalamin tablets are available in the UK. Injections used to be available. They're not available in the UK that much now, although some companies do send them out to people who do the courses from Spain. But really, it's not something we would use in the UK. Methylcobalamin comes in various forms, usually in tablets or sprays or patches or injections. And if tolerated well, it's very effective if there's neurological issues, nervous system issues with the B12 deficiency. And as you'll all know, there are many, many symptoms of B12 deficiency, and it's sometimes quite difficult to determine which symptoms are going to respond to what type of B12. So sometimes it's a little bit of trial and error with it. I do use methylcobalamin a lot with people. I tend to go for a lower dose. I tend to go for 500 microgram injections. And I do that mainly because it's quite useful as a practitioner, because it's non-prescribable, so you don't have to have a prescription for it, although I do prescribe hydroxycobalamin. So I don't have I can prescribe, so that's not a problem. And then adenosine comes in tablets and injections. And some studies seem to say that it's quite beneficial for people with Parkinson's disease or Parkinson's type symptoms. But it's a bit more difficult to obtain as an injection, and has to be tablets are readily available from vitamin companies. If one can take tablets, some people don't absorb them very well, so it just depends on the individual. But there's not really a one size fits all for everybody in the B12 world, as I'm sure you all know that. When looking for diagnostics and trying to diagnose B12, and we could go on for weeks about the issues that are with diagnostics, and that's not really what this is about. But it is very important to understand that in looking at cofactors for B12 deficiency, that you have a sort of baseline to work from. I always do a hemolytics panel, so I would always do a full blood count, and I always do a seroactive B12, and I always do homocysteine level. They're the things that I always do. I mean, I would always do ferritin, I would always do folate, I would always do thyroid, vitamin D. I might necessarily not do, antibodies and peripheral cell antibodies. And I find that it can be quite the symptoms between underactive thyroid and vitamin D deficiency can be similar to the symptoms of B12 deficiency. So in order to actually understand it all, you need to rule things out or in, as the case may be. So it's a question of doing the other tests just to make sure that it is in fact a B12 deficiency. And I don't always go by the numbers either. So I just wanted to talk a little bit about the blood checks and the skills and I don't want to say too much, but I'm not an expert, I may add, in interpretation of bloods. But over the years, I've understood a lot more about blood testing and about the values and what they mean, and how you can miss things if you don't really know. If you're just looking at the reference range, it says normal, 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 then there's at least a little point. But you do need to understand that what these things mean and what they can mean in relation to looking at the diagnostics and looking at symptoms and management of symptoms. So there are various things that I look for. I always look at the MCV, and that's the size and measurement, the average size of the red blood cells. Looking at the measurement of the hemoglobin in the red cells, and looking at the measurement of the average amount of hemoglobin in a single cell, looking for maybe macrocytosis, that's an enlarged blood cell, and often suggests low B12 folate. Macrocytosis, small blood cells can be low iron. Not always, but it can be a sign of a low iron. Red blood cell count, obviously the measurement, the amount of red blood cells, and then the width of those blood cells, and if they're small or large or normal width. So it's not just a question of looking at the results and saying it says normal, because I guess there's stories on this group alone that could say that maybe your B12 level was said to be normal, but it wasn't. You weren't normal at all. So hemoglobin is part of that as well. Of course, that's about oxygen, and it can be low in iron deficiency, anemia, or bleeding. The hematocrit's about the volume and the total volume of the blood, and that can be decreased in B12, but is decreased in B12 deficiency. white cells, you might not think that amounts to much, but actually it's really important because it could be inflammatory things going on. Ferritin is an inflammatory marker as well as a measure for sort of iron stores. And if the white cell count's up, then it might be, and the ferritin's high, it might be that there's an inflammatory aspect to it. So we have to, look at that and understand that, and then look at the other things, platelets. Platelets can be low in B12 deficiency. And I've said before, the ferritin can be really falsely high, and you can have an underlying deficiency, but it looks high, so because there's an inflammation going on. So I always do other things like the total iron binding capacity or saturation levels, that kind of thing, just to make sure how much ferritin is actually being transported, and that's important. I always do those. I don't skimp on those tests because, as I say, ferritin can be up for lots of reasons. So, so interpreting the bloods and looking at the bloods is really important. And there are certain patterns that you see over time with pernicious anemia or B12 deficiency, you get to know it after a while, and you get to know what you're looking for. And there can be lots of reasons for these. It's not always the B12 deficiency, it can be other things. So it's I say all this, I don't want to, this is not a blood interpretation lesson, but I say all this because the skill is actually knowing what the red flags are, a mix of a high or low MCH or MCHC or an MCV is a red flag for low B12 and low iron. And so I do take I have a couple of consultants actually who work with me, I often ask their advice on things like this if I'm not too sure what's going on. So it's important to, just kind of understand. You've got your other things like eosinophils, and they can be elevated because of allergies, but also they can be elevated because of, parasitic infection. We all know that one of the causes of B12 deficiency is a parasitic infection. Looking at the calcium levels in vitamin D and looking at parathyroid and thyroid, TSH and T4 and things is important as well. And I'll talk about them in a little bit later when we talk about vitamin D. Some people get a bit confused, I would say, about supplements and B12 supplements and folate supplements. And I think it's something that I just wanted to really talk about because folate is really important in B12 deficiency. And so, the B12 supplements, whether they're oral or sublingual or transdermal, absorb into the bloodstream without reaching the tissue. So things can look normal, and actually it could be false. It might not be normal, so it might not be getting to where it needs to go. Eating and drinking B12 fortified foods can have the same false effect as B12 supplements. Folate supplements might correct the size of the red blood cell, and it looks normal, but it's masking an underlying B12 deficiency. Low iron prevents B12 metabolizing and converting to the active form and transferring to the tissue. If somebody's got chronic kidney disease, then there can be issues with their B12. A functional B12 deficiency when transcobalamin 2 is either too low or ineffective at transporting B12 to the cells, then B12 will remain in the blood, causing the levels to appear normal. That often happens when you have a serum B12. You could get a serum B12 of 800 and still be deficient in B12. So it's very important to look at the other factors and also to discuss that, So, and some people don't understand that. They say that number and that's, it's too high or it's high enough. And actually the person's suffering from, severe symptoms of B12 deficiency. Inaccuracies of testing in labs, and I could talk for forever on this subject. Different labs have different ranges, and different ranges in different parts of the country, and and the different equipment they use, and the different ways they measure it, and how it's measured, and what the reference ranges are set at, and who the manufacturer of the machine is, and the differences in the calibration, and so it seems madness to me that I can get my cholesterol done in Newcastle and it's 5, reference range, and I can get it done in Edinburgh and it's the same. But when it comes to B12, it's a different matter. It's depending on which lab you're using, the reference ranges can be very different. And I think that's one of the issues that we as a charity have found all over, that really, if you're in the southern parts of England, your B12 can be 130 and be considered normal, and yet we've had that number in Borders in Scotland, where I am right now, it would be considered deficient. Some places have a reference range of 300 or 350, and other countries like Japan and they have a reference range of 500, and anything below 500 and you're deficient. So it's it doesn't help when you're trying to diagnose B12 deficiency, and it doesn't really help when you have that issue everywhere. So there's a lot of misconceptions about B12 deficiencies. So masking is when the levels of the blood may look normal because of supplementation, but you're not getting the correct reading. Now, sometimes, I don't know if you've experienced this or not, and I'm sure we can discuss at the end, but some GP practices would measure your B12 level when you're taking B12. And, it's absolute pointless in doing that, because you're, whatever reading you're going to get, it's not the correct reading, is it? Because, you're supplementing. So it has to be done, in my opinion, on symptoms, and, if B12 is making you better, and not, what the level might be. Fortification of foods, we've kind of said that before, can cause the same effect as the B12 supplements. And, because it's absorbed into the bloodstream without reaching the tissue, then it looks normal. And then we have to stop it, for at least 4 months. Because long-term supplementing can cause false B12 levels for, for longer than 4 months, but it can cause the B12 levels to be false. And it isn't, it's not great for the person. Folate, looking at folic acid. So starting folic acid without vitamin B12 can be dangerous, and is dangerous and shouldn't be done, because it can mask and worsen neurological damage caused by B12 deficiency. So folate supplementation can correct amegaloblastic anemia, which is a hallmark of both folate and B12 deficiency. That means that if somebody's deficient in B12, taking folate might normalize their red blood cell size and hemoglobin levels, and look like everything's okay on the on the blood tests, but actually it's not okay, because there's an underlying B12 deficiency that remains uncorrected, and it can lead to progressive nerve damage. So it worsens something called subacute degeneration of the spinal cord. And as we know, B12 is needed for the myelin formation, which protects the nerves. So let me just say, I know you probably know this, but this is a wire, okay? And the outside of this wire, just pretend it's a nerve. And this wire here, this white piece here, is the myelin sheath. And inside of here are the nerves, okay? And inside of here, as we know, there are, 3 wires, okay? You plug it in, you plug this into the wall and it works. But sometimes, if your myelin sheath, this white bit, is damaged in any way, then the connection doesn't happen. The connection doesn't work. And so it's the same for the myelin sheath. Sometimes, you know, you can, so sometimes people have, you know, these episodes where sometimes everything's okay and the next minute it's not. And I really, you know, without enough B12, the nerves of the spinal cord just start to degenerate and lead to symptoms like numbness and tingling and weakness, difficulty walking, balance problems and cognitive decline. And if somebody is given, you know, given folate, if folate is given without B12, the neurological symptoms may progress unnoticed, and then you've got irreversible damage. And that, you know, maybe some of you have experienced that. I hope you haven't, but maybe some of you have. And that's why it's really, really important to understand that starting folate before you have diagnosed a B12 deficiency, if there's an underlying issue, you will get problems. And it's really important that people don't do that unless they've obviously, you know, it's been ruled out. The other issue is the role of homocysteine. Now, homocysteine is an amazing blood test to do. It just tells me so much about the person when I do a homocysteine level. And both B12 and folate are required for the conversion of homocysteine to methanoin, which is vital for the DNA synthesis and for the brain to function. And if folate is given without B12, homocysteine levels might remain high, and high homocysteine levels puts people at risk of cardiovascular disease, things like strokes and you know, heart attacks. So it's so important, you know, if somebody's got a high homocysteine level, to bring it down. And the B vitamins bring down homocysteine levels, particularly B12. And risk of misdiagnosis and delayed treatment. Well, if anemia is corrected, but but neurological symptoms persist or worsen, then we might miss the, you know, the B12 deficiency diagnosis. And that causes permanent neurological disability if the B12 is not replaced in time. So my key message about folic acid is always to ensure adequate B12 levels before starting folate supplementation, especially in individuals at risk of B12 deficiency, vegans or elderly or those with malabsorption issues, you know, like a pernicious anemia or Crohn's disease or ulcerative colitis. And ideally B12 and folate should be supplemented together when needed, because never folate alone, just never folate alone when you suspect a B12 deficiency. So I just wanted to say that because a lot of people get confused about folate and B12, and it's so important. I always check it when somebody comes to see me, but one of the first things I'll say when I'm into the B12 consultation is, are you on folate supplements and what dose are you on? And you know, why do you take it? What was the underlying issue there? Before I would ever give anybody a B12 injection, I really need to know what that is. So it's important to look at it because of the masking issue. I'm going to move on now because hypothyroidism is one of those things that is closely associated with a B12 deficiency. And you know, why is that? Well, it's often present because there's, you know, there's overlapping issues going on. Obviously, there's the autoimmune connection between, you know, hypothyroidism or Hashimoto's and pernicious anemia. And the most common cause of hypothyroidism is Hashimoto's thyroiditis, which is autoimmune, and it attacks the thyroid gland. People with one autoimmune disease are at higher risk of developing another autoimmune disease. So pernicious anemia, a leading cause of B12 deficiency, is also an autoimmune condition. And so you just have to be careful and rule it out. And that's, you know, I would always do a thyroid level with, you know, when I was looking at, you know, somebody's symptoms, to rule it in or out, as a case may be, in talking with a client. So low stomach acid is, you know, is actually a problem in hypothyroidism. And thyroid hormones help regulate the stomach and acid production. So it can lead to low stomach acid, which reduces the body's ability to absorb B12 from food. And this is because B12 absorption requires the stomach acid to release B12, you know, from food proteins before it binds to intrinsic factor. I'm sure you know all this. Also, slowed metabolism and malabsorption. So hypothyroid slows down the gut, leads to, you know, digestive sluggishness and things like SIBO, if you've heard of SIBO, which is, you know, bacterial overgrowth, constipation, or nutrient malabsorption. The medications that people take, you know, about you know, it causes B12 depletion, things like well, thyroxine is one. Other things like, you know, metformin and statins, and, you know, omeprazole and lansoprazole, and so there are lots of other you know, medications that people take that might also cause issues with the thyroid and with B12 deficiency, because it worsens it because of the reflux, the absorption issue. So people do take, you know, acid or reflux for acid reflux, which, by the way, is because you haven't got enough acid, not because you've got too much. That's a whole other story. Shared symptoms and misdiagnosis. So, you know, both hypothyroidism and B12 deficiency share similar symptoms. So, you know, we need to rule things out or in. So fatigue, brain fog. You know, people say to me, tiredness, and I just, well, I think it's not tiredness, actually. It's fatigue. It's a whole different ball game from tiredness. Brain fog and memory issues, depression and mood changes, numbness and tingling, neuropathy, hair thinning, weakness can be hypothyroid problems, but it might well be you know, an underlying B12 deficiency that people don't look for. So I've found in many occasions over the years that when I have given somebody even just one B12 injection, the thyroid actually comes back normal. And it had been abnormal prior to having the B12, and just a month later, after one injection, I've seen it switch. And that's because I have a point of care testing machine which measures the TSH, so I can do it just as a single test when I've started somebody on you know, B12 injections. So it's important to just understand that, you know, people with hypothyroidism should be really tested for B12 deficiency because of the coexisting issues that there are between them, and to trying to figure out what is exactly going on with somebody. I mean, giving somebody a B12 won't harm them. It's water soluble, and it's not something that, you know, you would be harmed from. But you don't need to have it if you don't need it. And it's important to find out what is exactly going on with people. And when we come to other vitamins, this is just a quick run through really of some vitamins that work alongside B12, and I do a lot of you know, I do a lot with vitamins, actually. Anyway, when we're talking about thiamine, which is B1, it's often associated with alcoholism and malnutrition, and it's used alongside B12 if those issues are present. You need to combine folate, thiamine, and B12 is quite you know, common as well. Dietary induced B12 deficiency may need other things like trace elements because of mental health issues. You know, B1, for example, thiamine is well known to cause neuropsychiatric disorders if you know, untreated, and it's you're deficient in it, and it can go on to cause issues like, you know, memory loss and dementia, Korsakoff's, and even death. B6 and niacin, alongside zinc and copper, manganese and magnesium, have been shown to have a really beneficial effect on mental health as well. So the B vitamins are really important and work synergistically together. However, you don't want to be overdosing on them. You know, you need to be very careful about what you do take and how you take it, and you need to contact, you know, your provider, whoever you're you know, working with, or your GP, to look at, you know, some of this, because you can overdose on particularly B6, so we have to be really careful about how much you know, how much B6 people have. Nicotinamide and niacin, you know, B3 and B12 work together to support energy production and methylation, and nervous system health and DNA repair. A deficiency in one can worsen the effects of the other, so it can lead to fatigue and neurological system issues, symptoms, and cardiovascular risks and poor cellular function. Ensuring adequate levels of both is critical for brain function to be optimal, metabolism, overall health. Some of the differences between or the similarities and differences between vitamin D deficiency and vitamin B12 deficiency, some of them are very similar, but oops, it's gone too far. Anxiety, you know, can be a cause of a vitamin D deficiency, but you get bone loss and osteoporosis with vitamin D deficiency. But some of these cognitive issues and depression, anxiety can also be present when it comes to B12 deficiency. So you know, it's really very important to you know, either well, do vitamin D levels as well as vitamin B12 levels is important, I think, to rule in or out. Now, most of us are really, in this country, are deficient in vitamin D, and it's you know, can be recommended to take it between kind of October and March, depending on the circumstances. And we want the vitamin D levels to be you know, between 50 and 200 usually. So again, we have to be careful, but we have to, you know, either add in or rule out when it comes to other vitamin deficiencies, because they do have similar signs and symptoms. So vitamin D and B12, both are really essential for the nervous system health. B12 supports the myelin sheath, which we talked about. Vitamin D plays a role in nerve regeneration, reducing neuroinflammation. Deficiencies can in both can worsen nerve damage, leading to numbness and tingling and brain fog. And 2 seconds, I'm just gonna. That's better. So yeah, but deficiencies in both can worsen nerve damage, leading to numbness and tingling and brain fog and cognitive decline. B12 is essential for red cell production and energy metabolism, and it prevents fatigue and weakness. Vitamin D plays a role in mitochondrial function, helping muscles generate energy efficiently. So, you know, low levels of one or both of those can exacerbate the fatigue and the weakness, and you know, it worsens the symptoms. Vitamin D and B12 both support the immune system. Vitamin D modulates the immune system, reducing inflammation. It gives you protection against infections. B12 is involved in white cell production, supporting the immune responses. Deficiencies in both can lead to increased susceptibility to infections or autoimmune diseases and chronic inflammation. And then the enhancing of cognitive function and mental health, while B12 supports neurotransmitter production, which obviously influences the mood and memory and brain function. Vitamin D receptors are present in the brain, affecting serotonin levels by reducing depression risk. So deficiencies in both are linked to brain fog and depression and increased risk of neurodegenerative diseases like Alzheimer's. Vitamin D and B12, bone health and muscle strength, while vitamin D is essential for calcium absorption and bone strength. B12 is needed for proper osteoblast bone form and cell function. Deficiencies in both are increase the risk of osteoporosis, fractures and muscle weaknesses. So conclusion about B12 and vitamin D is they work synergistically to maintain energy and neurological health, immune function, and an overall kind of sense of well-being. So deficiencies in both can worsen symptoms like fatigue and nerve damage and cognitive decline. Supplementing both together ensures optimal absorption and function, particularly for individuals with autoimmune conditions or digestive issues or chronic fatigue syndromes. Mother, this is my mother. I do want to talk about it because she's the reason I get so passionate about B12 deficiency. So this is her in 2013. In May 2013, she was diagnosed with vascular dementia. The symptoms were dramatic weight loss. So going from a size 16 to a size 4 in about 4 weeks. It was massive. Depression, anxiety, increased suspiciousness, hallucinations, violence, aggression, lack of coordination. B12 was 168, but not considered deficient. November 2013, lots of issues. Admitted to hospital, and the first time she'd ever been in hospital in her life, they found an old stroke on the scan, but it wasn't supposed to be, significant at all. And then they found a pulmonary embolism on the scan. And then later that month, she was diagnosed with vascular dementia. She was admitted to a unit, an older people's unit, she was in for about 6 months. 2015, a massive stroke. Her homocysteine level was so high. Our B12 level was 52. And she was never given any replacement therapy. And as a clinician at the time, I was really, I suppose I wasn't as bold as I am now. And I was kind of I thought, well, I could inject, I could give her B12, and and I was worried about doing that for lots of reasons. One, that she couldn't actually consent, and two, that I knew she hated injections, and so it was a difficult one. And eventually I didn't do it. I didn't give her it, but I watched her die quite a horrible death. So this is her after the stroke. We had her at home for 2.5 years afterwards. And this is the day she died, interestingly enough. So suffice to say that, had she been treated, we might have had a very, very different outcome. She was only 76 at the time, and fit woman, walked 6 or 7 miles a day. Just, very fit. You would never have guessed it. Oh, but her brother, in November 2018, so she died in June, he died in November, B12 deficiency. He was diagnosed with Parkinson's, lots of other issues, and in actual fact, his B12 was it was about 10, I think, and it was just horrendous. So that's when I looked at the hereditary, the family issues, and I looked at the whole thing, and I saw some patterns, evolving, and that I still do to this day see patterns evolving in the younger members of the family. So Anyway, he fell, he broke his hip, I think it's quite a pattern really, falling, breaking your hip and then having a hip replacement and dying as a result of that. So they're buried beside each other in the graveyard, interestingly enough. So anyway, that's all I wanted to say, really. I mean, I wanted to talk about maybe just a few resources that I've found really helpful over the years that you've probably all got. But the best book ever is this one. I love this book. Here it is. I've got copies everywhere. I've got my signed copy for Dr. Chandy, which he gladly did for me a few years back. And one of the ways that I get people to sort of go onto the website is because the symptom checker here, we're in the middle of revamping it as such, as a charity, but it's a very, very good calculator, a very good diagnostic tool for people to, see, and for patients and clinicians to, refer to. It's excellent. So I just wanted to plug it really, because it's a really good tool to use. I use it all the time. And I have it printed out and such as well, because it's not been available really lately. But I do really think that this book is full of case studies. It's full of evidence. It's full of research. Hugo and Dr. Chandy did this together, and it's quite a brilliant book. So it's one of the best books I've come across in terms of clinical practice, really, and I refer to it all the time, because B12 is such a huge subject in terms of the symptoms that one person might present with compared to another. But it's quite a useful resource to have if you're in practice, and it's free to download chapter by chapter or buy the book on Amazon, it's sent out very promptly. The other books that I've found helpful have been this one, particularly this one by Sally Patchlock. The pediatric edition is quite useful for you. One of the issues we have in the B12 world is that children are often, missed out, and it's something that the other charity that I work with, that's why I do too, is they're really interested in children and children's issues. So I try and sort of spread myself across so that both types of support for the patients and clients are there really. So and then that's some resources that you might find useful. You probably know about them already. But that's me. I hope that was okay.
That was absolutely brilliant. I can remind people the book is still free to download. Download it whenever you want to. If you are buying a paper copy because you like reading it on paper, and incidentally, the paper copy is cheaper than printing it on your own printer at home.
Yeah.
There's a black and white version and a color version. Normally, you find the black and white version because that's about £6.50. But if you want the color version, it's around £23. And I have to tell you all that up front. These are the cost to print. We don't make a profit. That's why I have to say it's around this price, because it depends what price it costs to print on any one day. And you can print it anywhere in the world, of course, if you buy it from Amazon. You can download it anywhere in the world from our website, unless there are some countries that consider us subversive. There might be. So do get hold of Dr. Chandy's book. Do read some of the other books. There are some excellent resources out there. Dr. Chandy's book, some people have found quite heavy going. I'll make no bones about that. It's written as a medical textbook. And so we say there's 26 case studies in it. It's worth getting to know the people in the same way that when you joined here, we invited you to get to know the people by talking to each other. It's the same with the book. Get to know the people before you start trying to tackle the text. The text's hard going, but that's It's really good, and as I say, you can download it for free. If you are a doctor or a nurse and you're in the UK or any healthcare professional, actually, then email us if you want a paper copy of the book, and we'll send you a paper copy of the book for free. Coming back to some of the questions that are on the chat. So I'm going to start with how common is B12 deficiency with atrophy of multiple systems? Now, I don't know if the reason you're asking that is because nobody knows, or if there might be some work that's been done on that. Annie, over to you.
Yeah, I don't know is the answer. I really don't know.
Someone else is asking. I'll go straight
I
on
just don't
because
know.
there's a high chance that nobody has any answers on that. Unless someone puts their hand up and says, "I'm a researcher and I happen to have researched on that." Why would a patient that takes 5 mg of folic acid every day and self-injects every other day experience numbness and tingling around the ankle area?
Oh gosh, well, there could be lots of reasons for that. I mean, it might be a sciatic nerve issue, or it might be another issue, not a B12 related issue. It just needs investigating, but and obviously, I don't know how often, that like the blood tests are done, and does that person having enough? Do they need another, a B vitamin? Do they need a vitamin D? It's could be lots of reasons for it, really. So it just needs to be investigated as to why it's still happening. It might be that the person's not been on B12 very long, or when the symptoms are just getting better as such. Because very often, numbness and tingling can be a good sign in terms of like nerve regeneration, etc. It doesn't always be
Like when a
negative.
wound heals.
Yeah,
Yeah, wounds itch
exactly.
when they heal, and that's a sign of them healing. I've tried to explain the body to engineers, medicine to engineers, and engineers believe that something breaks and you know about it straight away. And of course, the human body is designed so if something breaks, then something else takes over for a bit, because we've got to live without. We didn't have doctors for tens of thousands of years. We've only had doctors for the last probably 2,000-3,000 years. There was an awful lot of humanity before then. We didn't have nurses until 400 AD, really, because if you had a broken bone, you went to a Roman legionary and asked them to fix it. And it was only when the Romans left Britain that we needed nurses. I bet you didn't want to know that.
Yeah, I think it's interesting.
So yes, it could be any number of different things, and that's the thing with particularly with nutrition, that we're eating food with no food in it.
Yes.
So
Yes.
so we end up with lots of different deficiencies, but you don't know which one. And about the only thing that's definitely safe to take is B12. Everything else you shouldn't take beyond a certain amount. I
That's
think
right.
vitamin
Yeah.
D is pretty safe, but some are not. So um, Emma asks, I've got an underactive thyroid and didn't know it. It could affect the way B12 absorbs.
Yes.
There's some really interesting stuff. I thought I never understood how the B vitamins all got lumped together in one group and they don't come from the same foods and they affect different things.
Yes.
Um, so Lisa asks what kind of clinician Annie was. I can't see it in her website.
Oh, that's probably because you're on the wrong one. I've got 4 websites, and they each do different things. But I don't know what I call myself. I'm a nurse background, but I kind of work in I run my own clinic. I have a CQC registered clinic in Scotland, and so it's my business, and I run it. I do health checks and things like that. So MOTs. I do quite a lot of stuff, I'm not just I don't just see people with B12 deficiency, I see lots of different people, but yeah, but it's really important, I would say, for me personally, that that the whole body is you know, taken care of, if you like, that actually I do an MOT on somebody, you know, to find out what the blood pressure is, all the things are, ECGs, etc. I do all of that. It's thorough. It's very thorough, and I think you have to be thorough, and that's what people miss. A lot of the time is like, you know, look, GPs have 10 minutes to see you. I've got 2 hours. You know, that's how it is. But then, you know, it's a private service. But anyway, so yes, I'm a clinician, but with a lot of experience in advanced practice and clinical examinations, etc. And I used to be a lecturer at Sunderland University on a master's in pharmacology, and then I did a lot of work with Teesside and a lot of other universities. So yeah, there's some things that B12 is just a big part of what I do, but not everything.
And that is crucial to point out that Dr. Chandy kept on stressing that although we have this protocol for diagnosing B12 deficiency, he always took the view that B12 deficiency was only diagnosed if nothing else could be found.
Yeah.
So you work your way all the way down this set of symptoms, and it's fairly conservative in how it even comes up with a diagnosis in the first place. And then when it says you've got a diagnosis, it then says, or it doesn't say, but he used to say, we then give them B12 injections for a fortnight and we see if anything's improved. If it hasn't,
Yes.
it probably isn't B12 deficiency. If it has, it's like giving a thirsty person water. You know, when you see a plant dying from lack of water, you don't say, I'll give half of the plants water and half of the plants not water. You say, they're short of water, I'll give them water. Should be the same with B12, really.
Yes, and I think the other thing to add in there, Hugo, is that very often, you know, some forms of B12 will work better with others than others on people. So I could give somebody hydroxycobalamin and there's not much of an effect, and I give them methylcobalamin, there's a big effect. So it just depends on the person. I don't respond to hydroxycobalamin, but I do to methyl. And so people are different. So if you've got like, you know, it's really important to do the history and to figure out what's going on with somebody. I had somebody, just a young girl, in the other day, and you know, her mum's on hydroxycobalamin, and I gave her one. It didn't make any difference to her, and I gave her methyl the second time I saw her, and she's like, oh, so you know, it's trial and error sometimes with the different forms.
Yeah, everybody's so different and
Yeah.
everybody's unique. We all know we're unique, but we have the evidence in medicine as well. So yeah, there isn't one size fits all. So there's a daily recommended amount. Well, that's the daily recommended amount for healthy people. For people suffering from B12 deficiency, they've got all sorts of different problems, which is what I'll be talking about next month.
Yes.
Whether it absorbs well, whether it can be used once it's inside the body easily, and so many different variations that you end up having to do it a bit by trial and error. You've probably got frustrated with your doctor when you've gone in to be treated for something, and they've said, we'll try this and come back in 4 weeks and we'll see if we try something else. And the simple answer is we don't have personalized medicine yet. At the point that we've got everybody's genome, their whole gene sequence, then we can start finding out how to do personalized medicine. We can't even find out how to do it till we've collected the whole of the genomes. So we're a long way from personalized medicine, and it's still quite a lot of try it out and see what happens. It's like the television not working. You thump it.
Yes, that's right.
You know, you don't know that you thumped it in the right place. And I'm not suggesting your doctor should thump you, but they do have to sometimes try different things. So absolutely. Anyone have chattering of their teeth as a symptom? So the reason that's one of the questions asked for Annie, we've noticed nystagmus, which is flickering of the eye.
Yes.
We've noticed various palsies. I wouldn't be surprised at chattering of the teeth because of the nerve. It's the most obvious impact of B12 deficiency is nerve damage. and nerve damage can cause that. Annie, do you want to say something more?
I think that's about it, really. I can't think of anything else. It's not something I've come across before, really, but I can see how it would. I can see the logic and how it would work, happen. But it's not something that I've seen at all, really. It's not something I see.
Yeah. Yes. I hadn't heard of it before, but what's the website address for the checker? We haven't released it yet. We haven't published it. It'll come out in the next newsletter. In fact, there might be an interim newsletter to say the check has been released. It's still got to go through. The trustees have got to say it's ready to release to the doctors. Then we've got to release it to a group of friendly doctors who are then going to review it and say, we think you need to change this word here, or we think this is not safe to put on, before we can then say to you, you can start playing with it. And then, of course, when we tell you all it's going to be ready to play with, then you'll all play with it and it'll break the server. That's fine. Just come back a little bit later on. Previously, we used to save your symptoms. This time round, we're not. Now, we're not doing it because it's much, much simpler to get a checker up there that doesn't need to save anything anywhere. And, of course, because we're still working on the security to make sure that we have a reliable back-end system. So what we've designed, the way we've designed it is that you can print it to PDF or do a screen grab on your smartphone and store them, and then you can see how your symptoms change over time. And it does put on a marker on the picture of the flowchart, and he showed you the flowchart. It puts a time and date on that flowchart so that you can see when those symptoms were taken. So that's not ready yet. And what else have we got? Someone else said, what about the WhatsApp group? The WhatsApp group was we haven't relaunched one yet, a new WhatsApp group yet. So it's still the old one. It's just changed its name back to B12D this evening during our conversation. But I'm tempted to say it's no longer reliably going to be talking about B12D. So I think we'll still start our own. But it's a conversation that Annie and I and the other trustees need to have. Where are we? I can't see what the first book was called, please. B12 deficiency in clinical practice. Someone's already responded to that. That's excellent. And if you want a copy for your GP, we can't send copies directly to GP practices. They go straight in the bin. It has to be requested by a doctor or nurse or other healthcare professional. And we will then send it to them. And if they've specifically asked for it, then obviously their receptionist won't throw it in the bin. But if you've any idea the kind of stuff that comes through the post for doctors, they'll have samples of this. They'll have quite expensive equipment, and the receptionist is just told if it wasn't requested, it goes in the bin. So we only send on request. If you want to take one into your doctor, then once again, request one and say that you want to take it into your doctor, and I'll still send you one for free. No problem. We're here to spread the word. Could we have the last slide again with the resources? And then while you're putting that up, I'll ask the next question. Any insights over long COVID, POTS, dysautonomia, and B12 or low B12 deficiency or low B12 history? Any connection with long COVID?
Well, you want me to answer that? I think possibly studies have shown, that the spike protein from the B12 stops the spike protein from replicating in early studies. So does vitamin D. So I think there is a link between long COVID and B12 deficiency, in the sense that in the research I've done, and I'm not an expert in this part, I may add, it seems to show that B12 helps the symptoms of long COVID, and they're quite similar. So that's as much as I know about long COVID and COVID and B12, but it's worth it's worth looking at.
Fantastic. Yes. I had not realized that research had been done. That's really good because you did a talk on B12 and COVID at the time. And all I was able to say was if you're a bit healthier, you're less likely to suffer from the symptoms. Bear in mind
Yes.
with COVID that you catch it, it's just whether you suffer from the symptoms or not. So all of these vaccines and everything else just mean that your body's fighting back earlier. So you suffer from almost no symptoms if you and you don't transfer it to anyone else if you've been vaccinated. You still have to catch it in the first place for the vaccine to do anything. Continuing the important work Dr. Chandy started, Radio 4's Great Lives program presented by Matthew Parris is likely to be interested in Dr. Chandy's work. So it requires a nomination by someone who knows him. Thank you very much, Jay. We will have a look at that. Mary asks, how do I request a book to be sent to my practitioner in the USA? I would advise going on Amazon and seeing what price it is to buy in the USA, in which case you wouldn't have to pay postage because you just buy a copy printed in the USA. It's printed on demand. There isn't a stock of these books anywhere. So when you say in the USA or when you say in Singapore, I want a copy, then it goes to the local Amazon printer. The local Amazon printer prints a copy and it arrives. So it's worth checking. If it looks like it's considerably more expensive in the USA than getting it in the UK and having it posted to you, then we can handle that. But in the first instance, see what it would cost to just get it in the USA. Where can we get homocysteine levels checked? The GP says she can't test. This is Stella Barron. I think you do a test, do you, Annie?
Yes, I do. I do a hemolytics profile. I don't do it on its own, so I do have a point of care test that measures homocysteine levels in 15 minutes. But to be frank with you, I'm not really convinced in the reliability of it, even though I'm just not convinced. I prefer to send it to the lab. And I use one of the top 10 labs in the country to measure my blood results based in Teesside actually. And so it's so I do the hemolytics profile. So that's like your homocysteine, full blood count, folate, active B12, ferritin. And then I don't do MMA because it's just too the lab don't do it, so I just don't do it usually. But yeah, so I kind of did. That's the homocysteine test. It's £85 if anybody's interested. Quite expensive. It's just you might get it cheaper through Medichecks or something like that as well. Medichecks or Thriva, is it? There's a couple of these postal bloods. You can get it in the post and you can send it back. So they're probably around about. I think they're maybe a little bit more expensive than the lab that I use, but I can do it in Gateshead or I can do it in London. I can do it in Scotland.
Stella, where are you based? Or do you want to write down Annie's?
I'm in Lancashire.
Okay, so
I don't
that's
think
quite
you've
a
got anything.
distance.
Glasgow is probably the closest, is it?
Yeah.
Yeah, man. Yeah, but
Mind you,
Jedburgh would be
it's for my sister really, it's not for me, but I can see the family links. But we are coming up to Glasgow to a wedding in August, that way anyway. So that's
well, you
we can
might
bear that
pop
in
in and
mind.
get it done.
Mm,
Yeah,
right.
you can get it done.
And what price was it, did you say? I missed that.
It's 85.
All right, that's okay. Thank you.
You're welcome.
Come for a wedding and get jabbed while you're here.
Yeah.
It's so true.
Yes.
Helps, that's all that matters, isn't it?
Yeah.
I've put down for people ordering books, I've put down an email address. All I do with the email address is I put an order on Amazon. I don't have a stock of them, and they come direct to you from Amazon. I need your post. If you're ordering, I need your postal address because otherwise the Amazon can't deliver it anywhere. It's amazing how many people forget to put a postal address. And also, I actually require a phone number to send it on. Where are we? We've got as far as restless leg syndrome. Oh no, we've got a whole lot more before then. Beware of hormone vitamin D issues, says Jay, where the UK practice remains to only measure the pro-hormone calcidiol, and that doesn't give you the full answer. chronicillnessrecovery.org. I don't know if you know anything about that issue.
No,
Different
I
things
mean,
you measure.
I mean, it's a huge issue, vitamin D, in lots of
Yeah.
respects. In terms of, it's not a vitamin, is it? It's a hormone, you know, but it's called vitamin D. Yeah, there's lots of issues with it, and you know, lots of issues around, you know, calciferol and the effects of it without K2, and it was just a whole, you know, other ball game really. Quite happy to talk about it, Jay, if you want to message me or something privately, but it's a whole other, you probably know more about than me anyway. I just measure it really.
Yes, yes. Please share your website address again.
Oh, okay.
Mary asks, would you share a list of cofactors you take? It's a difficult one because I'd be tempted to say you need to work out which nutritional supplements work for you, because there are so many that it would be inappropriate to get the ones that work on Annie and then expect them to work for you. Would you?
Yes, I think that's important. Look, I do vitamin reviews. Okay, so I will look at the vitamins that you're taking and tell you, you know, whether to continue them or not, and based on the effect that they have on your health and also your bloods. And so, like you have a medication review, I do vitamin reviews, because people just go out and buy rubbish all the time, you know, Holland and Barrett, wherever, and don't buy them, because they've all got bulking agents in and you know, additives in that are horrendous. You know, there are places to get vitamins that are very good and places not to get them. And so it's, yeah, not one size fits all with them. You know, it's a whole other, you know, ball game. But I'm happy to talk about it because I know quite a bit about vitamins, but it isn't one size fits all. And like, you know, Hugo says, some vitamins suit some people and not others. And you can overdose on vitamins, and you can cause yourself harm on vitamins just as much as you can on, you know, on medication. So so people need to take it seriously and be careful about, you know, you'll get somebody who buys a multivitamin and then they'll buy another multivitamin and they've got the same ingredients in, or they've got similar ingredients in. So you're taking twice as much as you need to or should do. You might start to get increased anxiety with some vitamins, you know. I was taking a B complex recently, and I started to get some weird sensations, you know, nerve issues, and I looked at it and it was B6, and I'd only been on it for 2 months, you know, but it was causing me issues. I stopped taking it. So it's a science in itself, and you know what I mean. It's this whole other, it's a subject in itself, and it's as important to me to see people, when I see people, I say, what are you taking over the counter? You know, and what interacts with what, because it's not just like go out and get some vitamins. It's really important to have it done properly. That's my thoughts anyway.
Yeah, very, very much so. It's we're all different, and we shouldn't pretend we can mimic what someone else gets and assume it works. And that whilst parents and children are close, they're not identical. So you could need different things. Richard asked the same thing as a couple of other people have asked. How do you find the working frequency and dose of IM or SC B12 injections that works
I never
for
say
you?
SC. I don't like it. I would never advise anybody to say. I don't tell them to do it. It's too big an injection. It's 1 mil, and it causes a lot of bruising, and so I just don't advise subcut. I use IM. I use in the leg or the deltoid. Yeah, I'm just not one of those people who do that. I do use a smaller needle, and I've just started doing that in the last 6 months. I've started using a 16mm orange needle, the same diameter, 25 gauge, but and it's but people are not getting, it's not as well, it's not sore actually, because the B12 I use doesn't have any additives in it. It doesn't sting, so it's a painless injection. But yeah, I think I'm not in favor of subcut. Some people are, so, but I never do it, and I never teach it.
Yeah.
And for B12, but other things, yeah.
So on the frequency, the easiest way is to record your symptoms. So if you record your symptoms every day after you inject, then you'll soon see when you can see symptoms coming back.
Yeah.
It might be something that you didn't necessarily associate with B12 coming back first, or it might be that tiredness comes back, or it might be that someone who's close to you says you're becoming grumpy or you're becoming withdrawn. We used to find when we started people on B12 in Dr. Chandy's practice that the first thing that was noticeable was that they were more sociable. Now, they didn't know. They'd always assumed it wasn't that they were irritable. It was that everybody else around them was irritating. And it took a while to realize that actually it was them. And once they had the B12, and they were suddenly a whole lot more sociable. So, yeah, to work out your frequency of injections, you're going to have to just keep track of your symptoms for a few months while you work out what the best amount is. The amount, I'm tempted to say you're probably already injecting 10 times more than you need. The amount you inject is typically 14 times more than the whole amount in your body if you're a 60 kilo person body weight. So you can cut right down the amount you inject, but the frequency that you inject, how many days between injections, is really important.
Yes.
And that you just see how your symptoms go.
Yes. I'll tell you a story. I look after the Benedictine order of nuns all over the world, and I'm responsible for their health. And long story short, one of them came over from France in November last year, and not last year, year before. Anyway, she had eyesight problems and almost blind, and she hadn't told anybody, and she's in charge, so she couldn't. So she used to delegate to other people. Long story short, I gave her a B12 injection. 20 minutes later, eyesight came back. 20 minutes. And then I thought, what? And I'd never seen anything like it. And I thought, well, I was in a monastery, so I thought, it was a bit divine intervention, or is this B12? And I thought, well, maybe it's both. So next morning, 18 hours it lasted, eyesight went. So I thought, well, I'll give another one, same thing happened. So, there's your clinical trial, really, it worked. And so then I put her on, she just injected every day while I was there, because I taught her how to do that. And then when she went back to France, I set her up to get her own B12, and then she injected every other day and then weekly. And she's on weekly now, and she's doing really, really well. But everybody's different, but honestly, I mean, that was a miracle to my estimation. I was like, wow, that is amazing. It's happened to me twice it's happened. So there you go. It can work instantly.
We had someone who was deaf since childhood, started on the B12 and was at a football match and had to take his hearing aids out because he suddenly could hear again.
Oh my God.
40 years later.
Oh, lovely story.
Yeah, it affects your nerves. It makes your nerves start working again.
Yeah.
It makes you as normal as you'll ever be.
Amazing.
That might not be very normal for some of us, but it's still as normal as you'll ever be. Why does stress lower or use up my B12?
What? Oh, sorry, what was that?
Stress. Why does stress use it up?
Well, I just think that you're being you're overactive in many respects when you're stressed, and it might even be the B12 might even be the cause. The low B12 might even be the cause of the stress. It depends how it exhibits itself. So it can be anxiety or, almost like hyper, ADHD type symptoms, or it could be lots of things, so sometimes it's a deficiency that causes it. So you might need it more, you might need a lot more B12 than you're having, but it's, like Hugo says, it's a frequency, it's not the amount you get. I only ever take 500 milligrams of a microgram, sorry, of methyl. It's just a small dose, but it's a frequency that matters. So I think sometimes it's just an exacerbation, or you need it more, or it just depends what the underlying issues are. I hope that makes sense.
So a lot of people are asking, they're asking your contact details, your website, and they're asking where they can get methylcobalamin. The simple answer is go back to the email. You'll find it's already in the email.
Yeah.
If you want methylcobalamin, then in the UK, you can get it from Oxford Biosciences, and that's so convenient. Yes, you have to mix a bit of saline in. What you do is you get some 5 ml or 10 ml, the plastic tubes which have saline for eye wash in them. And if it's 5 ml, you put 2 of them in, and if it's 10 ml, you put 1 of them in. You don't have to measure. If you can't get 5 or 10, if you have to get 20, it suddenly becomes a whole lot more difficult. So if you can get the small ones and just tip them in, you don't need to measure accurately. If you want Annie's clinic, then have a look on the email I sent out with her details talking about this talk, and you'll see it in there. And just follow through on there and you'll get to her website. I'm going to say it's now 9:15. So even on a 7:30 start, we've been going quite a long time. The thank yous are already coming in and people are leaving. So thank you very much, Annie.
Well, thank you.
And I'm sure everybody's found this extremely useful. Well, everybody has. We can see on the chat that oh, here's another one. One of these ones that I like reading. Eilish has said, my eyesight has improved for the first time in over a decade. 10 months of every other day injecting.
Wow.
Now, we've had that as well. We had someone who put away their crutches, came in on 2 crutches or a wheelchair, 10 months later was able to walk. And it's because we could demonstrate that there was improvement every time she came in for a review. And that was a teenager. So that was a young person, young teenager. And because we could say these symptoms have improved, we could say she's still improving, so she still qualifies for the every other day until no further improvement. So
yes,
sometimes you do have to keep up the every other day injections for a long time. I mean, I'm still on twice a week injections.
Wow. Yeah. Like you say, no two people are the same, and it's whatever suits you and works for you. And some people, I mean, I know Heather, for example, she's still on every other day, and she mixes adenosol with not literally in the vial, but she mixes hydroxy and then she'll have a methyl, and she might have an adenosol, so she kind of mixes the 3, and it that works for her.
Yeah.
Everybody's different, and you can top up in between. You can have sublingual sprays and tablets and stuff like that. Sublingual tablets for some people work. So it doesn't always have to be injections.
Yes, our studies suggested that people needing B12, 2/3 of them were fine on tablets. Now, okay, we were diagnosing 1 in 5, but they were all people, as I explained at the beginning, they were all people who, when you gave them B12, their symptoms improved. This wasn't, we think they're B12, therefore they're B12. This was, we've put them through for the final test, and the final test is, do their symptoms improve? So, yep, the tablets work for some people.
Yeah, I mean, I always do, like when I start somebody on it, I always do the homocysteine 3 months later, and the reduction, the homocysteine is always high, and the reduction can be half, in 3 months.
Yeah.
So it's like I do monitor it in terms of like this, almost like a little study I do, because I do monitor them and make sure that it's coming down and it's making a difference symptomatically, but also evidence in the labs.
Yes. Thank you very much. Thank you for all
thank
the
you.
wonderful notes back to Annie saying thank you very much for the great talk. It will be 7 o'clock next month. I will try and make sure that I get a message out. I hope that we will be able to release the current symptoms checker, but obviously if someone says there's something wrong, it might take time to put right. The trustees are checking it at the moment. I think the trustees have got a few questions anyway. Then it goes to a panel of doctors. And look forward to seeing you next month and to talking to you by email in between times.